Sorry about that. Hello, my name is Joy Ashby Cornthwaite, and I will be your host for this episode of the live stream show, MyDiabetesHQ Live. Despite advancements in diabetes medications, estimates suggest that only half of those living with diabetes meet glycemic targets all around the world. This results in an extended period out of target values, which puts people at increased risk of diabetes-associated complications, reduced quality of life, and also reduced life expectancy. In this episode, we will cover clinical inertia and suggest techniques towards better outcomes. Today's episode is coming right up. You don't want to miss this. Before we begin, a gentle reminder that the information and the content shared during the My Diabetes Live broadcast is not intended to be a substitute for professional medical advice, diagnosis, nor treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding any medical condition. Good morning, everyone. Sorry about the glitch earlier. This weekly broadcast is developed by and produced by Cities Changing Diabetes volunteers here in Houston and Philadelphia. Both cities are in the network of 30 cities working to improve diabetes prevention, care, and management all around the world. This past week, Berlin and Belgrade joined the global network. Willkommen and Dobrodošli. You will learn more about Cities Changing Diabetes by going to citieschangingdiabetes.org. The purpose of this live stream is to help people with diabetes and their support teams. And today we're reviewing the topic of clinical inertia and moving the conversation to ways to engage and move towards better glycemic control. Leave a comment, share where you're coming from, and join in the conversation. We'd love to hear from you. So today, let's begin with just a definition of what is clinical inertia. That is when treatments are not initiated or not intensified to achieve target glucose goals. It has been cited as a major reason for poor diabetes care outcomes. This includes failures or delays in establishing appropriate targets, escalating or de-escalating treatments in order to achieve treatment goals, and prevention of overtreatment by recognizing that for some people living with diabetes, they may be at risk to harm due to high or low glucose levels, other complications, or, for example, cardiovascular events. So today we have two wonderful physicians with us. We have Dr. Ajay Rao. He's an endocrinologist and associate professor at Temple University. He serves on the advisory board of Cities Changing Diabetes Philadelphia. Good morning, Dr. Rao.
Good morning. Thanks for having me on, and excited to be on.
Yes, as usual. Thank you for coming on.
Happy to be here.
And next we have Dr. Annette Gadabeku. She is a primary care physician and an associate professor at Drexel University College of Medicine in Philadelphia. So we have our Philadelphia team with us here today. Good morning, y'all. And of course, Drs. Rao and Gadabeku will be joined by our My Diabetes Live panelist, Serena Valentine. Hi, Serena.
Hello, everybody. Good morning.
Good morning. Serena is CEO of Core Initiatives and Houston's Diabetes Peer Support Initiative Program Coordinator. So let's begin with you, Dr. Gadabeku. Can you start us off by just talking about what clinical inertia looks like in care?
Sure. So the main points to consider as a physician or a provider and a patient is really on the basis of being patient or person-centered in terms of management, education, and just having really in-depth discussions and asking questions, recognizing that everybody's body is different everybody's circumstances is different. So there is no one perfect way to manage and treat diabetes. There are several options, and we need to really explore what options are best. This starts out with providers asking questions about patient circumstances that might be work-related, financial-related, what they feel comfortable with, and then also encouraging patients to ask questions and say when they don't understand what's being said, and saying they don't feel comfortable. So setting those targets right away, being very clear about what sugar targets we are aiming for, and then what are the options of management, whether it's oral medications, insulin, injectable options, and adjusting those when it doesn't work quickly. Being engaged with the patient on a regular basis as to not prolong time where diabetes goes unmanaged or there are complications. And really using your support staff, ancillary staff, support resources, people like Serena, diabetic educators like Maryanne, those people that can really assist in trying to educate, trying to help, check in, adjust management plans, treatment options, medications, education as quickly as possible. It's really important just to have that really close patient and provider and support staff relationship, so to make the best outcomes for the patient.
I think you're muted, Joy. Yeah.
Sorry about that. In summation, I think you're saying that the importance is having a strong clinical team, as well as open communication with that clinical team, and then increasing sort of personalized goals and priorities into that conversation. Would you say that's true, Dr. Rao, as well?
Sorry, I have some Wi-Fi problems, but I think can you guys hear me okay?
Mm-hmm.
Yeah, so I 100% agree with what Dr. Gadabeku mentioned. I think this is a constant problem that I notice. My sense a lot of times is what I try to do is kind of stack up the last 3 A1Cs, and show it. These electronic records are so nice. I can show the screen to the patient, and we can kind of go over like what did we do, in the last 3 times these A1Cs were measured, and in a sort of a shared model. And again, that doesn't always have to be that we increased a medicine, but it also could have been, hey, we started doing other aspects of what's so important when you're living with diabetes. And I get a sense that sometimes when you put those 3 A1Cs before you start thinking, oh, wait a minute, maybe, whether it's the provider or the patient, we recognize that maybe we're not moving forward in the right direction that we should be. And I think that I love the goal setting. The goal setting is so important. Because I think a lot of our patients and providers don't set goals, and that's where the challenges are.
And so, Serena, as a patient, as our physicians here are telling us that the goal setting and communication are very important, what are your thoughts about? And I know we talked last week about, or a couple weeks ago, about shared decision making. How do you feel as a patient hearing this, as someone living with diabetes?
I think it's so very important for to set goals, because normally if you don't talk to a patient about goals, most likely, unless they're a self-starter, they're not going to think, okay, I need to set a goal to get this done. It's not that they don't know how to set a goal, because everybody sets goals at some point in their life about anything. I'm going to get all my stuff done today. Okay. I'm not going to miss anything. I'm going to drink my water today, or I'm actually going to be happy today. I'm going to be positive. Those are goals too, but a lot of people don't think about that when it comes to diabetes. And it's very important for, it could be a physician or maybe somebody like me, peer support or diabetes educator, somebody to mention to the patient that there's some goals that have to be set, and if you set them, you can't just set them, you have to work on achieving them as well. So yeah, it's very important.
Yeah, so I'd like to kind of take all of the information that the three of you have just touched upon and see if we can look at it in terms of what are some concrete thoughts and some concrete things to do in your sessions.
So I'll just say, in terms of, for me, for communication, I'll give a couple of examples. I can think of two patients that I recently encountered. One was in the hospital and one was in the office. One was a gentleman in the hospital who was started on insulin, I think a few months ago, and he came in with very uncontrolled, very high sugars, and we were about to discharge him, and no one had really yet. I kind of came in at the end of his hospital stay, and nobody really had a discussion of whether that was going well for him. And we found out that he had some housing insecurity issues and actually wasn't able to really had a place to store his insulin, and was going to maybe try to get to his sister's house. But he was on a regimen of like 4 sticks of insulin a day, and that just wasn't going to work for him. Another example was a young man. He was in his 20s, newly diagnosed, came in to the hospital, was a hospital follow-up, and he was seeing me for the first time after being diagnosed with diabetes, having sugars in the 500s, and just very, very uncontrolled, and didn't really know what was going on. But he was discharged on a regimen of taking a long-acting insulin at 8 a.m. every day. And he actually worked for UPS, and his shift started at 4. So he was expected to wake up at 8 a.m. and take his insulin and maybe go back to sleep. And so could you imagine, he wasn't really getting up and doing that. He wasn't really motivated to do that. But did he have to do that? Absolutely not. We could have changed what time of day would have worked for him so that it would be more easy for him to actually be adherent to his medication regimen and actually understand how that works and why it needed to be done at the same time every day. So really just adjusting, that's what patient-centered means, and patient-centered communication, finding out what are the barriers, what are the challenges, and really adjusting the regimens for them so that they can be successful.
Yeah, those are two great examples. They're very common. When on paper it looks like, I should do this medication in the morning, and then in reality, that may not be someone's morning. And
Right.
so just asking a question like, when do you wake up would help that. And a lot of times patients may not even know that that's an option.
Right.
Great, y'all. So what's another tip, would you say? Dr. Rao, or?
I think, I guess the other thing is sort of really going through, I don't mean to keep on emphasizing the medical record or the electronic medical record, but I think that it's so nice that we have these tools. And I think it's important to make sure what somebody's thinking that you're on, for whether it's medications or whatever it may be, from the provider standpoint, that's what the patient is actually doing. And I think a lot of times providers sort of might get into this habit of just, writing what they think the patient is on. And patients, I think, need to engage and look through that list and say, hey, am I actually doing these things? Am I actually taking these medicines? Or is it really not actually happening? And I can't tell you the amount of times that I'll be like, oh, you're supposed to be on this medicine, right? And they're like, oh, no, I told Dr. X that I'm not on that medicine. And so I think that's another important point that I sense that is really nice for patients to look at their list and see, is that what I'm taking? Is that what people think I'm taking? Am I supposed to be taking but not taking it? And that's, we struggle so much with that. And for example, as me, as a specialist, sometimes I'll see these patients and it's more of just re-emphasizing what their providers have been telling them. I do nothing. I just say, thank you for coming, but please just do what Dr. Gadabeku told you already to do. And they just haven't been doing it, so I think that communication is important.
Yeah. So, jumping off of that, and I wanted to talk to you all about how partnerships work with primary care physicians and specialty physicians. And I love that you've already had, brought up the thought of making sure that there's a medicine reconciliation, which is what we call it in clinics, but just reconciling between your visits from your primary care to your specialty, and then having that communication between physicians. Can you both speak to how that works, that relationship works?
Sure. It is a lot of partnership, and it's partnership on so many levels. Partnership between the primary and the specialist and the person and patient. So, and there's so many different scenarios. There are people that get very attached to one doctor or another. So they may, only want to, talk to their primary or only trust their primary, and Dr. Rao is their specialist, and they'll come back to me and say, well, Dr. Rao said, but what do you say, Dr. Gadabeku? And I'll, of course, reinforce what Dr. Rao, and vice versa. They're, especially people with chronic illnesses, they don't want to see multiple doctors. So sometimes they're like, primary, forget that. Dr. Rao, you're my doctor. You're my diabetes doctor. You're my everything doctor. So what are you going to tell me to do? And so that's where sometimes Dr. Rao would say, you really need to go back to your primary and make sure, because I'm just looking at your diabetes only. And I'll try to think about all the other things, but that's what Dr. Gadabeku as a primary doctor is better at, looking at the whole picture and how things fit together. And then we can talk. And then there's many times where I've reached out to a specialist like Dr. Rao, and, I'm concerned that something's not being done or adjusted and by the patient, or I'm not sure of the patient, or I'm seeing the patient and I want to make an adjustment, but I don't want to step on his toes, and I don't know all the time, what is in his head and what his plan is. Most of the time we do, because we have the electronic medical record and we can see, but sometimes we can't. So there are times where we'll reach out to each other, vice versa, and say, hey, there's this issue going on. Do you have a recommendation? A patient's here with me now. How can I adjust things and have them follow up with you? Or vice versa, where a specialist will contact me and say, oh, they were seen in my office today. I'm concerned about this. Could you help watch this for me, or reinforce this with me? So it really is, it can be a really great partnership and collaboration. It doesn't always happen that way, but if it can, I think it's really, really good to try to have the patient understand why it's important to have the two type of physicians in their care.
I agree. And so now Dr. Gadabeku and Dr. Rao have talked about the clinical arm of sort of combating and overcoming clinical inertia. I know that Serena has some insight, because one of her suggestions is self-advocacy. Serena, can you talk to us about how you use that to overlay with what our physicians are saying to make someone move forward their care?
Yes, so I'll just talk about myself, because nobody talk about me like me. But me, for example, I think a lot when I perceive a lot of the bigger picture. And so if I see that something's going on, for example, I had a similar situation that was kind of like the situation that Dr. Gadabeku mentioned about a guy, I guess a young guy. He was working different hours, and the regimen wasn't working for him. I used to work at a chemical plant. I was 21, going on 22, and I was working 12-hour shifts, rotating shifts. So it would be 4 on, 4 off, 4 on days, 4 off, and then 4 on graveyards. So I was really like jacking up my sleep patterns by waking up in the middle of the day to take my insulin to eat. And then I was like, well, if I ate during the day, you know, I was thinking still on, like I'm still on days, maybe I shouldn't eat at night. But if I was working the graveyard, I was up all night. So my blood sugars were all jacked up. I was just like, I don't understand what's going on. So when I finally went to my doctor, I talked to my doctor about it, and he told me, he said, well, what's going on with your A1C, Ms. Valentine? Are you not following the instructions? Or, you know, I'm like, I'm following what you're telling me. I was like, but sometimes I work at nights. Every other week I work all night, you know, from 6 to 6. And I get up in the day, and he's like, oh, you're jacking up your sleep patterns, Ms. Valentine. And so he was like, honestly, I wouldn't recommend you work rotating shift like that. You messed it up. But he said, if you're gonna do that, he said, you're gonna have to eat while you're awake. You're not gonna have any energy. And I was like, okay, all right. But I said all that to say that I would go talk to my doctor about any little bitty thing. Like, it doesn't even matter. Like, if I'm feeling a certain type of way, if 1 or 2 numbers are off during the day, I'm just that way. So I would recommend, if you're a patient and you see anything strange or anything that's not normal to you, or it may have been your normal, but you're wondering about it, please talk to your doctors, please, because they can help you. If you don't say anything, how do they know what's going on in your body? You know, and talk to all of them. I know how, you know, you have your specialty doctors, and you have a PCP, primary care, you have an endocrinologist, you have a cardiologist, a podiatrist, a dentist, and all. Talk to all of them. You know, they may not be all in the same network, but you need to communicate with all of them. Communicate. So that's my recommendation.
So it sounds like all of you have communication as your top.
It's crucial. It's crucial.
Yeah.
It's so crucial. Or else, you know, I mean, I think what Dr. Gadabeka said really, you know, reeks from, you know, sort of so important to me, because I have a lot of nice collaborations with primary cares where I may be seeing that patients every 6 months, and then they're seeing them in between, so that, you know, everybody understands this sort of team approach. And I mean, I tell my patients that in this day and age, there's plenty of ways we can keep connected, you know, if not more than we want, probably. But it's even what I mean in a healthcare protected way. A lot of our systems are now working with each other, and clearly here in Philadelphia we do this a lot. And I think patients, I'm not saying demand it, but they should say, hey, you know, here's my primary care. I know you're my specialist. You're my eye doctor. How are you guys all? Are you guys all making sure you're connecting with each other and everybody knows what's going on? And that's an easy question, I think, very open-ended, and providers should be, you know, open to provide their aspects of how they're actually connecting. And that reassures the patients, I think.
Yeah, that's excellent.
Yes. And making sure, you know, just asking again, if did you get the records from when I saw Dr. Rao? Are you getting those? Some of my patients, and sometimes I don't even know that they've started to see another specialist. Sometimes specialists refer to other specialists, and I wasn't even aware. So just making sure as a person and a patient that your doctors are getting the communication, and then facilitating in that way. If in that way, if you can say, okay, when I go back to my endocrinologist appointment, I'm going to make sure they have your name and your office information in their system to send you their notes or whatever. And then we'll do the same on our end. We'll get the name of the doctor in the office, and we'll say, okay. And I strongly encourage it to happen at both ends, because something always, you know, delays or goes wrong on one end or the other. So doing it from both ends is really, really helpful for everybody.
And I love that Dr. Gadabeka brought up that sort of that from hospital to back to outpatient setting scenario with this connectivity. Because I think on the outpatient side, sometimes it might be much easier, but then, hopefully many of our patients are not ending up in the hospital. But if they do, I think having that stack of papers, that discharge summary or those discharge meds you were sent home on, I think that's another place where there's some confusion after a hospitalization, what's the patient on and what they're not on.
Mm-hmm. And then to Serena's point of self-advocacy, making sure that you ask for discharge paperwork. And if it's not something that you can read, something that I heard from a patient recently was she left the hospital with a new medication. She was in fact told to come to the clinic. So she had an appointment with me, had an appointment with the physician, but she didn't know what she was on. She was Spanish speaking only. And so she was given paperwork in English. And so she could not read it at all. And so that's why she didn't know what she was on. But they assured her that while they did not have, paperwork, and maybe they just didn't know that they had paperwork translated, that someone in her clinic would explain it all to her. But here's this paperwork in English, So, and I told her during our session, make sure that you keep pushing for a translator and for she's learning English so she can understand it a little bit, but reading is a different thing, especially medical things. And so I made sure that I told her, next time if this happens, make sure that you push for in your language any reading materials or whatever. And so that's part of Serena's world, right, Serena?
Yes. I've even tried to work to get some, some publications and paperwork and flyers in different languages too. I'm working on that now because, America is a melting pot of different cultures, different people coming from everywhere, and you want to be able to serve everyone, So yeah, that's a major barrier to communication as well as the language. So yeah.
And literacy, not assuming that people actually not can read, but understand. I think sometimes providers take for granted that, it's on a prescription, they'll read the directions or the instructions. Someone may interpret the way it's written in the incorrect way or and affect the way they do take their medication. So again, it's important to review it and make sure that they understand, okay, this means take it once a day at whatever time, and make sure it's around the same time every day. And, whatever clarifications that you can give. And then again, on Serena's point, really encouraging patients to advocate for themselves and ask questions and say when you're not comfortable. One more quick example. I just had a patient I talked to last night who we were transitioning from oral to insulin. And, she was very overwhelmed. She has a lot of other things going on medically. And, but I know her to be very with it and on top of her regimen. So I offered an option for her to adjust her insulin quickly on her own. But she said, I'm not comfortable with that. I told her how to do it, and she's like, you know what? I'm not comfortable. And I so appreciated that because now I'm not going to leave expecting that she's going to do what I said and come back and it's not done. And it's good that she initiated that and said, I'm not comfortable. We can ask too, are you comfortable with that? And a lot of people will still say, and they're not. But that is what advocating for yourself is. If you're not comfortable, I don't understand, please explain this to me again. Using that to really, really help, because we think, yep, you're on your way, and it may not be the case.
Yeah. That's really amazing, Dr. Ganavecchio. I love hearing that you have those types of conversations with patients. And I know that patients appreciate it when it happens, because like Serena said, sometimes you don't even know that that you need something, or that you don't know something, or you don't understand something, unless someone kind of like primes you. Like, are you sure you understand? Can you? I usually say, can you repeat it back to me? Like, how would you tell your mom that you're taking your medications? And they just kind of look at me a little bit like, why would I tell my mom? And like, just pretend I'm your mom and you're explaining it to me. And I have really great relationships with my patients, so most of the time we're laughing. But
I mean,
but
that teach back is so important, right? I mean, I can't tell you the amount of times that I might ask somebody, you just want to kind of make sure we're on the same page. Can you just tell me what I just mentioned to you maybe 5 minutes ago? And then you hear that the response back, and then as a provider you look at yourself and say, clearly I'm not communicating well enough. And that's an important thing I think patients should be seeking from their provider, and even bring it up, and say, hey, this is what I heard from you, Dr. Rao, or this is what I heard from you. Is that what you mean? And sometimes it's fascinating to hear the discrepancies between what we're saying and what's being heard and comprehended.
Oh yeah, for sure.
Yeah, that's funny. That's me at the doctor. I'm the one that's like, okay, so what you're saying is, you want me to take this, and then they're like, well, no, but I want you to take this, but not like that. I want you to do this every so often. I'm like, oh, okay, so what you're saying, I have to do that, because I have to clarify. Sometimes I don't understand, and so yeah, that's me all the time. But my doctor always laughs at me. She's like, I know I have to repeat myself because you're always going to ask me again and again.
Awesome.
And the educators can play a big role here too, and I think we've talked about that a bunch of times. But they're so nice to help with that aspect. If there's again some barriers in some way, they can sometimes really easily break that down and be a nice person to sort of conduit between the provider and the patient.
Mm-hmm. Yeah. So I think you all have landed on another one. So you've got communication as your primary. You've got self-advocacy, and then this, I love that you've named it and like given a name to it that we use for other people to understand, but teach back. And teach back can go both ways, right? So from clinician to patient, from patient to clinician, the questioning of what's next. So there was something that I don't know if you guys want to get into today, or you want to, let me know where you want to go with the conversation. But I know one of the things that came up in when we had conversation offline was pattern management. And I think it's in line with what you were talking about, Dr. Rao, and then what you focused on later, Dr. Getabeku, which is looking at where you've been and then assessing where you're going to go together as patient center. And so would you guys like to talk about pattern management and what that looks like and what that means in terms of numbers?
Sure, I'll let Dr. Rao go first.
Yeah, sure. I mean, I think pattern management I think of is sort of how we look at these individual sugar numbers and sort of see where are individuals with diabetes having problems. So is it an issue that's happening when you're fasting or overnight? Is it an issue with your sugars that's happening maybe immediately or a couple of hours after a meal? Or are you having problems with low sugars after certain insulin doses? Now, the pattern recognition is great when obviously individuals have sensors, but we know that that's not possible for everybody. We hope eventually there'll be a time when it should be. But I think even with finger sticks, this can be very important, and trying to tell your provider what you were doing during these periods of times so that they can, when they review. So, really the review of this, I think there's growing evidence that how much time you spend in range is really crucial for your risk for complications. And so I think we really want all of our providers to be reviewing the data when it's provided to them, meaning either the meter download or
Oh, okay. So
Sorry about that. I know I probably went out there. So
That's okay. You went out a tiny bit, but I know that as you're saying, reviewing the values and the information takes it, like our title is, just beyond the numbers, so that you can see what else is going on, how much time a person has been in range, which is important, you say, to complications. And Serena, there's another layer that you like to do for yourself and that you like to encourage other peer supporters to overlay on top of that data. What is it?
Oh, I'm trying to think. Was it
Oh, you're
something we already
journaling.
talked about?
You're journaling.
Oh, yes. I know when I tell people about journaling, they're like, do I have to do that? Like, I don't have time for that. I don't want to do that. That means there's something else extra for me to do. But for me, for myself, it is very important to pay attention to the numbers. I did a short Facebook Live video this morning about paying attention to your numbers, because that way, if you see, I'm not saying you got to check 8 times a day, but find the times a day you want to check it and check it those exact same times every day. That way you can see what happened. Maybe you want to write down what you ate or what you did or what you were doing before you checked it or what you're about to do or something like that. Because I've been getting a lot lately, actually about 2 or 3 individuals from peer support that have told me about overnight lows and night sweats and stuff like that. So I'm like, okay, when you experienced this, did you write it down, or did you take your meter when you went to your doctor? Did you tell your doctor, hey, I've been having these lows, I need to find out what's going on, I eat the same, I exercise the same, or nothing's changed? So journaling to me is very important. Now, me personally, I don't journal all the time. I check all the time, but I may start journaling if something's different, something changes, so that I can keep track of what's going on and I can tell my doctor later. So yeah.
I'll just reiterate, that's really helpful for us as doctors to bring those journals with you, even if we don't even ask you to interpret. Like, we can help interpret what the patterns you're seeing. I think first, again, communication and just explaining why one needs to check their sugars and record them. I think it's intuitive to a lot of us, but someone may not really understand, why do I have to do this? I don't like it. It's painful. How is this helpful? So just explaining that, oh, I actually get to look at these numbers and see how to adjust your medicine can be actually helpful. And then those pattern recognitions is really important when people are consistently high, and everybody's body is different. So there are regimens that we traditionally have people do at night or during the day. Because we know we eat a lot at night. I mean, during the day, we eat during the day and we sleep at night. So, most of our sugars are going to be higher during the day. And first thing in the morning, when we haven't eaten all overnight, they might be lower. So we might adjust medicines according to that. But there's some people, for whatever reason, have an opposite type of metabolism where their sugars go super high overnight while they're sleeping and not eating. We can adjust the medications according to that person, and that's that patient-centered management that we're talking about. Sometimes it's just really good to see what happened. So someone will bring in their list of sugars, and again, like Serena said, it doesn't have to be all day, every day. But if we can get, your sugar is just a snapshot. It's just what happened right then. You have your A1C, which tells us kind of how you're doing over 3 months. Having some short, pictures of multiple sugar readings, we can kind of recognize, oh, I see there tends to be a higher pattern during this time of day or time of day, or things are going really well, and then all of a sudden we've got a 300. What happened here?
Yeah.
Oh, that's when do you remember what you ate the night before? That's when I ate such and such. oh, you see what such and such does to your sugar. Oh yeah, I see it now. So this kind of gives people a better picture of what is actually happening when they eat certain things or when they take their medications a certain way, to adjust and adjust quickly. That's what we're talking about, the inertia, where we're waiting long time, especially now during the pandemic, and it's hard to get in with appointments and telehealth and all these barriers. Those numbers and sending them to your doctor, talking to your doctors about them or providers, it helps us to adjust things more quickly and not wait months and months and months before we get another A1C or another lab draw to make the adjustments.
Yeah, and reminding the providers too, right? When the patient comes in and has all this data, you really want to see your provider engaging and looking at it and actually reviewing it, and not just like taking the paper away or just, oh, thanks for doing that, And I love what Dr. Gadabeka said, which was, making sure you're asking provider, why do you want me to check it? Why do you want me to check my sugars 4 times a day or 2 times after meals or something? What's the reason behind that? Because I think if you know why you're checking, that helps you understand what to do with the numbers and how to feed back to your provider. And the providers should love that. There should be no provider not wanting that or encouraging that. Then you should be concerned as a patient. So because these are your numbers, right? It's not his number or her number. These are your numbers, and it's what what you're doing that might be changing a lot of those things.
That's really great information. So what I'm hearing, and I think what people living with diabetes are hearing, hopefully, is that there are so many more components to your care and to information that can help adjust your care and your care needs beyond the numbers, right? So a number is a number, but what's happening around those numbers is pretty important. It is not a grade. Have you all ever had that kind of come up in your conversations? Like, I don't check it because I feel like it's a grade.
This is crucial. This is crucial because I think sometimes, especially those on insulin, there's also the aspect of checking for safety purposes. And so you need to tell your provider if you're on insulin and have decided not to be checking your sugars, because then there needs to be some shared decision making there, and figuring out, because there needs to be at least a minimal check if you're on insulin, again, more out of safety, to make sure that you're not low before you're about to give yourself insulin. And I sense that that's always difficult.
I love how animated you got.
Yeah, I know that one. I was ready. I was ready. And then I'm warming up, I think. No, the last thing was the last thing I want to say is don't forget about asking your provider about whether you would qualify for a continuous glucose monitor. Sometimes surprising.
Yeah, let's wait just a moment and see if he comes back, because
you're here.
You're here.
Sorry about this. Must be there's some events happening that I think are changing my bandwidth here. But what I was saying is sensor availability. Continuous glucose monitors, whatever brand they may be available to you. Surprisingly, it's a technology that you could be on, which is helpful for assessing this sort of time and range aspect of things.
Yeah, and I love it. Oh, go ahead, Dr. Gadabeka.
No, I just wanted to say for Dr. Rao, like that's a great example of work partnering with a specialist, because they sometimes are like really, really up on all the different options for you, whether it's monitoring, whether it's medications, and actually really helpful in getting those things that may not be readily available or authorized or covered. They're very, very key in helping just identify and authorizing and pushing some of those up to date and state of the art technologies and medications and therapies for patients. So I just look, when he said that, because sometimes it's harder for us as primaries to do that. And that's another reason why we love working with specialists.
Yeah. And it ties in what you all are talking about right now, the transition. You're like, perfect. You know exactly where I'm going with this. But thank you for being such a amazing guest. But the conversation around technology can happen, in the peer support space with another peer who is using a bit of technology, and then to have that conversation with your specialist to say, is it available to me? As diabetes care and education specialists, we do a lot of the background work with our nurses to figure out, is it covered? Do we need a prior authorization? Do we need a physician signature? Do we have to have our physician do a peer-to-peer? And so again, look at this, y'all, communication showing up yet again. So this brings us to one of our resource slides that we had prepared for everyone as well, in terms of learning about your technology. The Diatribe is an online diabetes community that is amazing about sharing peer work. And there is a book by Adam Brown called Bright Spots and Landmines that can help you know all the things about maybe pattern management. There's a couple of really great chapters in there. Also talks about highs and lows and what may contribute to those to help you with your journaling. In terms of clinicians, ADCES, which is the Association of Diabetes Care and Education Specialists, do have continuing education and new information about advancing technologies and medications and how they're used to help train and educate patients and their teams. And then what I was looking at when I noticed we wanted to talk about Inertia today is that the ADA has an initiative, a 3-year initiative that is addressing therapeutic inertia in 2020 and beyond. And they have webinars that are available for free. You just register and they'll talk about the things that we talked about today and how to move your clinical teams towards reduction of therapeutic inertia. So these are just some patient provider resources that would be really great to get you going. What do y'all think?
It's great. No, keep engaged, and I've heard great things about all of those that you posted up, and I think across populations, a lot of people have smartphones. They can get on these things, and it can be really very helpful. And speaking to your providers about what they think about each one of those things is also important, I think. But I think individuals with diabetes, keeping engaged is so important.
Yes, capitalize on those resources, utilize those resources, utilize your peers, get as much information as possible, and support. I think just knowing that you're not alone and you're not the only one dealing with the challenges that you have, or even if you're well controlled, it's still a challenge to live with diabetes and to check and monitor and go to doctors and go to support. And but just knowing that you're not alone, that there's resources and there's actually people you can talk to or touch, and other people are going through this with you, and there's always new information out there. And actually, I encourage you to bring it to your doctor. Bring it to your provider. Say, hey, I just saw this, or I was on this group, and they were talking about that. That also keeps us on our toes and keeps us up to date. Yeah. A lot of times, some of the new stuff that I learn about comes from my patients first. And so really capitalizing on those resources and using them to your advantage is helpful for everyone. Ajay, you're on mute.
And Dr. Rao, Serena, would you like to also put in sort of your last insights?
Go ahead, Serena. You can go ahead.
Oh, okay. It just, I mean, it's important for patients to communicate with their doctors, as important it is for the doctors to communicate with their patients. But a lot of times it may be a little difficult for doctors to help you if you don't say anything. And like Dr. Getterbeck said, it is important to talk about these things, talk about what's going on, because you never know who you're talking to may be experiencing the same things, or they know someone who's experiencing it. And shameless plug, Houston Diabetes Peer Support Program.
Yeah.
We talk about everything, y'all. Like Dr. Getterbeck said, even if you're well controlled, it's still a struggle, and sometimes it's difficult. So we're on Facebook. If you type in the search box, Houston Diabetes Peer Support Program, click on join, and one of our admins will let you in. But my point is to say that it does help when you feel like you're not alone. I've learned so much from peer support. Everybody at peer support looks at me like an expert, and I'm like, I'm still learning. I'm still learning from everyone, because there's always something new to learn when it comes to diabetes, because it's a chronic illness. It's, long lasting. So there's always new things, new technology, new things. But please communicate and advocate for yourself.
Yeah, I think the group aspect in the peer support and group aspect in diabetes is so important. And I sense that, when I've seen when I've seen the success stories, it's usually because of not only providers and the diabetes educators, but also all of the peer support, friends, family members, and in group settings, learning together, and feeling like you're not alone. I think that's really, really the most important thing.
Mm-hmm.
Excellent. And I wanted to say for clinicians as well, I think that feeling of not being alone is important as well.
Mm-hmm.
I think we always think about peer support on just the patient side, but I am really, really well supported by my peers, as I know you all are, every day as I'm caring for people living with diabetes, because I can't do it all. I enlist in my pump reps, who are incredible people, to help teach me about new pump therapies or different ways to utilize the pump that might make my patients' lives easier. I utilize people who can teach us about the new types of medications. And they've gone virtual now, so that's even great. So I think clinicians also can look to peer support, maybe perhaps in a different way, but similarly.
I mean, we learn so much from our patients. I think that's also something that providers should feel very happy to get information from their patients and share that with other patients. The tricks that you learn is so helpful.
Yeah. I love that about the diabetes community. I think we are constantly learning from one another, and encouraging one another and cheering for the success of one another. I mean, from Houston to Philly, from everywhere, right? I think when one person living with diabetes thrives, we all share in that success.
Absolutely.
Excellent. Thank you all for being here. And I know we're getting close to the end, but we do have a few minutes left. So I don't know if there was some additional thoughts that you wanted to have a conversation about, or if we had some questions.
I mean, I think you got to know your A1C. Your A1C should be on a card, or you should be carrying around something that your last couple of A1Cs. Because I think the great thing about diabetes is it's so oriented around the A1C. And then another important thing, which I forgot to bring about it before, is, have you even had the A1C drawn? Finger sticks are equally important, if not more. And I'm not saying that, but I'm just saying the A1C is the only way. Remember, that's the test you're getting. It's going to some provider. Somebody should be acting upon it. And if you haven't had one in the last 90 days, you've got to be thinking, why is that not happening? And that goes both ways, provider and patient. You know, it's like it's your oil tune-up for your car. You know, and that's something we have an advantage with diabetes. Not a lot of other disease entities are not like that. So let's take advantage of it.
Yeah. Can we take the next few minutes, maybe Dr. Gadabeku, to go over what the A1C is?
Sure.
Like what is it? And then also there's some information like around it's like, well, maybe the A1C isn't the best thing to use. You know what I mean? Like, can we touch on that a little bit? Because it still is a really useful thing.
Sure. I'd be happy to. So I just want to reiterate, knowing your numbers is so crucial, and that's for everything, like your sugars, your blood pressures. Knowing your numbers is really good. You never know what situation you're going to be in, and you go to the hospital, you go somewhere, another doctor, and they can't get your records. They don't know, and it just gives us a good idea of what to do. It is the start to our roadmap. The A1C is actually the sugar content on the red cell, one of your cells in your body, your red cell. And the reason why it says 90 days, 3 months, 3 months, 3 months, the lifespan of a red cell is 90 days, meaning after 90 days, there's a process where it basically dies. And so when we check the A1C, it gives us a sense of how your sugars are over the last 3 months. That finger stick, like I said, is just a snapshot. It's only right then and there. But the A1C gives us a better picture of, because we all see, it's up and down sometimes, or sometimes really steady and up. So that gives us a more of a general sense of how well controlled your diabetes is. Yes, there have been some things in the literature about A1C and some of the challenges, and there are some specific challenges for people with certain conditions, especially conditions of the red cell, right? Because it tells us about the sugar content on the red cell. So if you have a red cell issue like sickle cell, it may not be as accurate. And again, that's why it's really good for everybody to know what conditions you have and put everything in context and have a primary too that can kind of put everything together. But it is what we have right now. I think one of the best ways to really help guide us. And like Dr. Rao said, seeing trends. Oh, is it going in the right direction? Are we going up? Or are we going down? Or where are we going? And and it starts conversation too. It starts that communication. Okay, the first thing when I see a person living with diabetes in my office, I know they're coming. What am I doing? I'm going to look at their labs from the last whatever months and see where they were, and then look at the trend, and then I know where to start the conversation. Okay, so looks like it's been creeping up. What's been going on? Or it looks like you've gone down significantly. Congratulations, like this is great. What are you doing? What have you done in the last 3 months that has gotten it down? And then we can reinforce those things. It's a great conversation starter. It's a great way of helping us to manage and see trends and see what to do, where to adjust. And so, yeah, that's basically what it is. I hope I explained it okay. But
yeah, you did.
Yeah.
That was great.
That was amazing. That was great. That was amazing. That's yeah. It's right on. Right on. It's and I think that you have to. I'm emphasizing another aspect. You have to also wonder when you haven't had an A1C, what's going on? Why am I not getting it done every 90 days? It should be in your calendar. Set a reminder. Because it doesn't always have to be paired up with a visit nowadays with telehealth and all these other aspects, educators that can help you. But it's that touch point that you want to have every 90 days. And then, of course, like Dr. Gadabeku mentioned, if there's an issue with your blood cells, you need to let somebody know because maybe that's not the test for you.
Yeah, that's so great, y'all. And Dr. Gadabeku's coming with like health literate, like information and education and all of this on her birthday.
Oh, happy birthday.
It's my birthday weekend.
Okay,
It's birthday weekend.
Even
Listen,
better.
Happy
the
birthday.
new thing is the birthday month.
Oh yes,
Yeah.
yes. It's my birthday month. It's my birthday week. It's right in the middle of the week, so I'm taking advantage of both weekends.
Yes. Happy birthday to you. And thank you so much for having this really, really, really important conversation and taking time out of your special, weekend to do that for us.
My pleasure. It is important, and I would do anything for MyDiabetesHQ. So that's why I'm here today.
Look, she's selling us, y'all.
Yes, I love it. I love y'all. So do anything for you. And so I'm here, and it is important. And I just just want to support and advocate for everyone. And so that's, that's why I'm here.
Yes, and we are so grateful to have you. I not only just adore working with y'all and hearing and listening to all of the important work that you do, but I love cheering for you too and for your patients and everything. So thank you all.
Thank you. Thank you so much.
Joy. Thank you so
So
much.
hopefully we will be back together soon. So keep your calendars open for us, okay?
Yes. Saturdays.
Yes, Saturdays.
Yes.
So thank you everyone for joining us today. It's time to wrap up our episode of My Diabetes HQ Live. Again, to our speakers, thank you all for being here so much. You're so talented, and I so appreciate that you're in the world of diabetes care with me. Mark your calendars, everyone. We will be broadcasting every Saturday, 10 a.m. Central and 11 a.m. Eastern Time. Our next episode will air on Saturday, November 14th, when we will lead an expert discussion on another critical component of diabetes self-care. Thank you for being a part of My Diabetes HQ community, and we'll see you next time.